Welcome to ASM Live at ICAAC. I'm Michael Schmidt. I'm one of the moderators of This Week in Microbiology, and it's my great pleasure to be here all this week at ICAAC, which is the Interscience Conference on Antimicrobial Agents and Chemotherapy. I have the great pleasure of visiting with many of the scientists that are presenting some of their cutting-edge research here at this international conference. Today we have with us two scientists. We have Cristina Masseria from GlaxoSmithKline and King of Prussia. And we also have Roger Baxter from Kaiser out in Oakland. So thank you for coming, and they're going to share with us their thoughts on the rise of pertussis in the elderly. Pertussis is this nasty disease that we associate with vaccination, principally DPT, diphtheria, pertussis, and tetanus. And it's the vaccination that protects us as children from getting whooping cough. But even as adults, we can come down with whooping cough, and it literally is 100 days of cough. So Cristina, please share with us some of the exciting findings from your research.
Thanks again, Michael, for inviting me to share the results of our research. What we did was trying to estimate what is the real burden of pertussis among mature adults. And this is because we know that most of the pertussis cases are underreported or underdiagnosed, but we don't know what is the size of the underreporting.
So why do you think they're underreported? People just, are happy coughing for 100 days?
There are many two reasons. First reason is that often pertussis among adults is not very severe and is often mild or moderate. And, we tend to seek care at a later stage as adults, so we try to see what is happening and then we go later to see a physician. The second reason is that diagnosis of pertussis often is also late. And this is because for adults, it's very easy to signs and symptoms of pertussis are very similar to the signs and symptoms of other respiratory conditions. And therefore, if physicians are not aware of the burden of pertussis among adults, they might think that is another respiratory condition instead of pertussis. So these are the main two reasons for which we have this high level of underreporting and underdiagnosis, in particular for adults.
So your paper is going to generate a lot of interest amongst our colleagues here at this conference because a lot of them are clinicians.
Exactly.
And so they're going to, come down and really want to know how they can actually help their patients appreciate the fact that they do indeed have pertussis.
Yes. Well, we used a very different methodology from what is usually used in epidemiology. We used a mathematical model to try to estimate the burden of pertussis. This methodology has been used in the past for other respiratory conditions that are often underdiagnosed and for which we don't always send patients for laboratory confirmed cases, and has been used in influenza, RSV. And what we find is that the burden of pertussis, the overall burden of pertussis among people 50 and older is I would say around 200, more than 200 cases for people, 200 per 100,000 cases for people 50 and older, and more than 400 cases per 100,000 for people 65 and older.
So that's one of the largest growing demographics in the United States and the developed world is those folks over 50. Yeah. So it is a substantial problem and a substantial increase.
It's a huge increase. If you compare these numbers with the national reported pertussis cases by the CDC, is more than 100 times higher for people 50 to 64 and more than 250 times higher for people over 65, at least in 2010. So big, big difference.
So why is this happening? We've all had our DPT shot when we were kids and we've been getting boosted for a while. So why is this happening now?
So most of these guys, I don't think they received DTaP or Tdap. So clearly they might have natural immunity because maybe some of the individuals, since Tdap and DTaP was not around in that period, so maybe they got pertussis, and once you get pertussis, you're immune. So that is one thing. But what is happening is that pertussis is still out there. And so, and often we just think about the infants or the children, because clearly this is our major concerns, and most severe cases are happening among the infants and the children. So our main aim should be to protect our infants. But the problem is that if we don't prevent pertussis, or if we don't diagnose pertussis at the early stages for adults, what can happen is that unknowingly they spread pertussis to the infants.
So they're the vector.
Yes, so we don't know if they're the main vector, but they could be a vector for spreading pertussis in the society and to our infants.
So then your model, looking at modeling the increases in this demographic of between over 50, it can really begin to address whether or not this age population is a reservoir that could impact on what's going on in our infants and children.
So I would just say this is a model. As I think someone said yesterday, all the models are wrong, but they might be useful. Some of them might be useful.
Models are wrong and they may be useful. That's a good quote.
I hope that this model is useful, and I would like this model to be useful for raising awareness. Pertussis is out there also among mature adults, and clinicians should think of pertussis when they see a respiratory condition, and maybe better case definition of pertussis is needed, or case definition that are more age appropriate, because pertussis cases among infants is very different from a pertussis cases among adults or mature adults. So it's important also to have age appropriate case definitions. And I think a couple of years ago there was a working group looking exactly at having different case definition. By Cherry and Tanya, I think they were looking at...
Yeah, I'm not sure that the case definition is all that important, though. What you said about people coming in or not is actually more important. So, you know, we work in a big, Kaiser Permanente is a huge medical care organization in California, and we looked at pretty much everybody who came in for a pertussis test, whether they were positive or not. And it's certainly true that people had milder disease as adults. But when we looked at the charts of people who'd come in for pertussis, even adults, even elderly adults, they were sick.
Yeah.
They were really sick for a long time. Some of them were vomiting. It wasn't recognized because people weren't thinking about pertussis. But I think the most important thing is that this is just the tip of the iceberg. Whatever we see, we have to do some sort of mathematical modeling, because we know that most people who cough for a long period of time may call in, may go to the pharmacy or whatever, but they generally won't go in for a medical office visit, and so they won't be diagnosed. But I also think that the adults, the elderly adults, are really the tip of the iceberg, because our study pretty well showed that the young people are the ones who are really getting the high rates of pertussis. So,
the 20-somethings?
No, actually it starts at age 5 and then goes up and peaks at around 10 or 11.
Okay.
And based on the way we analyze the vaccines, we think that as time goes on, these pertussis outbreaks will actually increase, and they will increase in older children as we move into an acellular only pertussis cohort. So people who were very elderly, they didn't get any vaccine, but most of them got pertussis. Almost everybody had pertussis. And then as we get into a slightly younger population, we have a lot of people who had whole cell. You know, whole cell's been around for, 1948. It was actually first licensed in 1914, so it's been a long time. But it's in the combination since 48. But it really wasn't so widely used in early years.
Because the whole cell vaccine was, I think for lack of a better term, reactogenic.
That's a good term. That's a very good term. And that's why we moved out of that and into the acellular. But not every country in the world did that. And when we introduced the whole cell, we saw a major decrease in pertussis. And I think that the whole cell pertussis vaccine probably was producing some sort of herd immunity, because we did see lower rates in everybody during the time that whole cell was out, and it was only in infants that it was given. But since we've introduced the acellular vaccine, we're now starting to go back and see more outbreaks of pertussis, and they're increasing. That's why in 2010 we saw the biggest outbreak in over 50 years in California. Yeah. But we saw most of the disease in the cohort of children who had had acellular pertussis vaccine, at least in California, it's mandated that they have 5 doses when they head into school, and most states are the same. So they hit that 5th dose at age 5. That 5th dose then starts to wane, and by age 10, it's not worth very much. So that's when they get their pertussis, and that's the kids who really got it. They're also the vectors.
Yeah.
That doesn't...
Giving it to the adults.
That doesn't mean
Grandma
that the...
and grandpa.
Yeah, that doesn't mean the adults are not important. They are super important, but they're not as big. So what I think you're saying is that if we're seeing this much disease in the elderly, there's a lot of pertussis out there, and
Yeah.
we're only seeing the tip of the iceberg.
Yeah, this is what is the message. So, and we need to understand better what is happening.
So let me ask you both this question. Do we need a new vaccine? Is the acellular vaccine not as, well, what you're implying is the acellular vaccine doesn't have the magic that the whole cell vaccine had, but do we need a new vaccine, or do we just have to boost like tetanus every 10 years?
Well, that's a very good question, and that's a very complex answer. And
I know.
The CDC has analyzed this and decided that boosters every few years is something that's not cost effective. They're going to be analyzing that over time, and they may change their minds. I think we can say that the acellular vaccine is very protective for the individual. As children get it, starting at 2 months and moving into those 5 years, they really are protected. So the younger children, the ones that we're really the most concerned about, really benefit from the acellular vaccines. And so we're doing our job. We're keeping them from,
You're keeping them from getting
they're-
bad outcomes.
Yeah, and the
from
little
disease.
tiny babies are going to be protected as we move into this pregnancy vaccination. Every pregnancy now, it's recommended that mom gets vaccinated with every pregnancy to protect the infant as is born. Those antibodies will cross over and protect the child for
Until they're ready.
until they get their first vaccine and get immunity from that.
So that it really addresses, is the acellular vaccine good? Because that's the operational definition of a vaccine, protection. And
Well, yes, but there's good and there's really good. So when we
Okay.
see something like varicella or measles vaccines, we see disappearance from the community of the disease. We are not going to see that with pertussis vaccines. I think that's what we can say, is that although it provides protection for the individual, it is not going to provide a herd immunity, and it's not going to provide what's going to blunt, but it's not going to stop pertussis outbreaks. In fact, probably the pertussis outbreaks are going to get slightly bigger over the future
So-
if we don't have a better vaccine.
And what we are going to do is merely, at the moment, what is happening, we are postponing the age
Of disease.
of disease. So
Yeah.
this is what is happening, and this is at least what we see. And but what is
So it
important?
goes back to your question of really making the practicing clinicians become aware as this population ages. They really need to put pertussis into their differential much earlier than they normally would. They really need to consider pertussis.
And what is happening, I mean, what I see, there are a lot of studies on children and adolescents, pertussis, because, I mean, clearly this is the main risk groups. And we see a huge increase in pertussis among children age 10 to 12 overall, and different studies have shown this. Adults, we tend not to look at them. And adults, as an adult, we tend not to complain. I mean, even if we have a mild cough, I mean, we wait and wait. And maybe we go to see a physician after 2 or 3 weeks, when even laboratory testing is not useful anymore. And so we really don't know what is happening among adults. And we are focusing most of our studies, which is right, on the most vulnerable population, that are the infants and the children, where there are more severe cases. What I think is that we need to look at the whole population overall, and we need to understand better what is happening with pertussis and with our vaccines. So because...
But on the other hand, it's a very good point that companies like GSK should use their wonderful adjuvants that they already have stockpiled and consider making a really new and better vaccine. We know that when we took away a lot of the other things, components of the whole cell vaccine, those were adjuvants. That's what those were. And we now have newer adjuvants, and GSK is on the forefront of adjuvant development. We have newer adjuvants that can produce the immunity without the reactogenicity. So I'm hoping that companies will move forward with some of these adjuvanted pertussis vaccines.
We are looking into developing
Yeah.
a new
model.
vaccine.
Well,
Hence your model.
I mean, in our model, we really didn't look at vaccination. The aim was really to look at the burden of pertussis. And the message is that we need better prevention and we need better diagnosis. So, and vaccination, I mean, CDC is clearly saying vaccination is important. And although we see that our vaccine is not as efficacious as we thought and is waning.
We have a question from the audience. Please.
Sure. Michael Smith, MedPage Today. A couple of these questions actually for you, Dr. Masseria. And I'm sorry if I've mispronounced that. The first one is you gave some incidence estimates per 100,000 population. I assume those are annual. That's just a technical.
Annual, yes.
Those are annual.
Yes.
200 per 100,000 annual.
Yes.
Can you give, then you said that those are much higher than the CDC estimates for those populations.
Yeah.
What's the CDC estimate for the population overall? Do you have that number?
I think the population overall was around 2 cases, the overall population 2 cases per 100,000.
Yeah, and I wish I could remember too. I have the graphs.
I think
if I'm
it's
not
around
ready to answer
2
that
per
question.
100,000. Most of the cases that are reported, because CDC, their surveillance system is about reported cases. So most of the reported cases are clearly among infants, where the incidence is much higher than the average incidence in the whole population. But I have the numbers, I only got with me, I'm sorry, the numbers for the CDC number for the age group 40 to 64, and in 2011 was 2.26 per 100,000. For the age group over 65, in 2011 was 1.38 per 100,000.
So your numbers are bigger by 2 orders of magnitude.
So for us, in 2010, we stopped the study in 2010. For the age 50 to 64 was 292 cases per 100,000. And for the age group over 65 was 464 cases per 100,000. So a very big difference.
And then the teens, or these adolescents, they're 10 times more than the adults. So you can see.
It's substantial.
Yeah.
And so for a company like Kaiser that's worrying about healthcare costs, how do you view Dr. Masseria's results? Is this of concern?
I think it's something we are all aware of. We've known about it. We started when the new pertussis vaccine came out for adolescents and adults, we targeted older grandparents, anyone who was having new kids in the house, and we were very aware that older people not only get sick, but are transmissors, are vectors of the disease. I think, though, that, the kids, the siblings and moms are more important vectors than the elderly adults. A lot of the elderly are much more isolated. If they aren't in contact with immediate families, they don't have the kind of spread that adolescents do.
Just to follow up again on the mathematical model. I wonder if you could just give us a sort of a rough outline of what sort of data was used to populate the model, what time periods it covered, that sort of thing. Just sort of a dumbed down version of the mathematics.
A very simplified version. So we use IMS data, and the time period was from April 2004 to December 2010. And what we did, we tried to estimate the proportion of cough illness that was attributed to Bordetella pertussis. And we did that by analyzing the relationship between cough illness and positive laboratory test. So we were looking at the time trend between cough and laboratory test and tried to understand what was the relationship between the two. We also correct for seasonal trend and secular trend, because we know that cough is a seasonal disease. Pertussis is not a seasonal disease, meaning peak of cough are happening during the winter period, while pertussis is happening all year round. And we also corrected for secular trend because we see an increase over time of pertussis.
Very much so, yeah. And pertussis, a very important part of pertussis is that, first of all, it's not global at one time. It tends to outbreak in local areas, regional areas, and it definitely produces immunity itself beyond a little bit of the vaccine. And those areas that then have a large pertussis outbreak, they're kind of free of disease for a couple of years. So that you'll see it going up and down all over and moving around the country over years. So even though these estimates are, you know, they definitely are helpful, they have to take into account a lot of movement, and so it's not a static thing at all.
Yes, exactly.
So one year, one thing in one area, one year, another thing in another area. It's a very dynamic thing.
Yeah, this is why we corrected for both the seasonal and the secular trend. And what was interesting was that we saw only 2% of the overall cough illness was attributed to pertussis in our, only 2%. So it's really, really small percentage.
Yeah.
I mean, we know most of the cough
2% overall. But I suppose in sometimes, yeah, it could be 10, 20%.
Some years were more, some years were less. But on average, between the time period, it was only 2%. But that 2% meant that, for example, for the age group 50 to 64, we moved from around 9,000 medically attended cases in our database to more than 500,000 cases. So a huge difference only for that 2%.
But those are all medically attended, too.
The 8,000, yeah, the 500
so there's a lot more than that.
It's an iceberg, as you said.
Yeah.
Please.
Jeff Fox, Micro. I seem to remember that a few years ago, the big outbreaks in California of pertussis were attributed mainly to conscientious objector families, those who opted out of vaccines for one reason or another. How are you factoring that in? How important is that?
Yeah, so that's a good question, but that may have happened early on when people said that, and it's true that some of our big outbreaks did seem to start in areas where vaccine hesitancy and refusal were high. But in general, the children who got pertussis were kids who were vaccinated. In our population, in a big health plan, our vaccination rates are very, very high. We still have refusers just like everywhere else. And those refusers are at much higher risk for pertussis, as has recently been published. It's just out in JAMA Pediatrics that children who miss 4 doses of pertussis vaccine are 30 times higher to have pertussis. So refusers are much more likely to get it. But that being said, they may be the pocket where it starts, but it spreads rapidly into areas where children have partial protection from vaccines, but definitely are not protected because the vaccine has waned. So it's all part of the story, and definitely vaccine, even not refusal and not even hesitancy, but just being late on vaccines can contribute to this a lot.
I have another question about the whole cell vaccine, and that is, has anybody given thought to using that, bringing it back into use for older children and maybe adults, since it is so much more effective, and the danger, the risk to the recipient, I would guess, for reaction would be much less as they age, right?
So there's a lot of thought being given to it. And in many parts of the world, the whole cell vaccine is still used. So it's in the United States and certain other countries that refuse to use it. In the United States, a lot of the problem was the litigation that happened back in the 1980s. By the time we moved to an acellular vaccine, there was only one manufacturer making a whole cell vaccine, and it was difficult to keep in business with that. So it had more to do with the fear of the vaccine. There were a lot of things that were attributed to the whole cell vaccine, which later on, through studies, were shown didn't actually come from the vaccine. They weren't actually caused by the vaccine, but it was too late. The fear was out there. Now, it's not just these severe illnesses, though. It is the reactogenicity. Kids get a lot of fever, febrile seizures, a lot of crying, these funny hypotonic episodes. So I think it's definitely not coming back for infants. I know that. Some people have said, well, the acellular vaccine, the problem may be that first dose, where you may be able to stimulate with a whole cell vaccine a better balanced immune response, where you get the full T cell response, you get a really good memory, and then you boost later on, where the acellular vaccine may not give you that boosting effect. So some people have thought that, well, maybe we should go with a whole cell on the first dose or two until they're primed, and then boost with acellular. And then other people have said, like you, well, maybe older people. I think that older people aren't going to benefit as much from a whole cell vaccine because it's a little bit too late. Their immune systems have been set up for this organism, and I don't know for sure. It's possible that now a whole cell vaccine would have a great response, but I doubt it. I think that once we've had a bunch of acellular vaccines, our immune system is set to recognize the organism in a particular way and probably won't reset and start all over with a great thing. So my sense is still that better to produce a vaccine that's less reactogenic and gives you great immunity, and we can give it to everybody.
You just gave me a qualifying exam for my graduate students. How does boosting work at a molecular level?
So at a molecular level,
You don't have
when
to
you say
answer.
molecular level, I don't even know what you mean by molecular
Well,
level. I mean,
you-
atoms don't boost, I don't know.
You were actually alluding to it in the beginning because you have memory, and what you're trying to do
Yeah.
is boosting is this novel concept, and what has to be in the boosting
Right.
agent in order to stimulate your memory so that you have the appropriate correlates
Right.
to protect you from subsequent exposures
Right.
and disease.
Is it toll-like receptors? Is it particular T cell lymphocytes? Is it particular cytokines? You know, everyone can tout one cytokine or another. I agree. We don't know
Yeah.
what boosting is. But I think that one of the things we know is memory. But we also don't know why memory. So that's what you mean by
Yeah.
molecular level. You mean kind of
Yeah.
why, right?
Yeah, that's the question that you can't get Google to answer.
Yeah, yeah. No, it would be wonderful. I do think that the adjuvant work has shown us a lot about what happens with memory, and I think we know enough about it. So sometimes we don't know why something works, but we know that it works, and we know that it's safe. And in my opinion, for what it's worth, knowing that it works and knowing that it's safe is pretty good.
That's the gold standard.
Knowing how and why it works.
Is great.
That's great. Oh,
That would
that's
be
the
even
best.
better.
That's gravy.
And that's where I want to go to. I think that's wonderful, but we're not there. Yeah.
Jeff,
Speaking of memory, hurry up because I'm going to forget my question. Let's forget about the adults. What about the kids and reverse? Use the whole cell when they're still malleable, but they're older than, older than infants or even adolescents when
No.
they're tough
I
young
hear you.
adults and
No.
but they still need
Yeah.
some kind of lasting
Immunity.
boost to their immunity that will take them through adulthood.
This is what we're you weren't hearing. This is what we were talking about, because we know with other vaccines that if your first vaccine is one that does not produce that boosting effect, if it's not a really well-balanced vaccine at the first pop, that later on, your next shot, you're not going to get this. You're not going to get a boost, and you're not going to be able to then revert and cause boosting. So we know that pretty well with the pneumococcal vaccines, that if, as an adult, you get the pneumovax, the polysaccharide vaccine, you will then not have a boosting response later on. If you get the conjugate vaccine, it's likely that you will have a boosting response. If you get the conjugate vaccine first, and then the polysaccharide, you'll boost to that one, which wouldn't have boosted in the first place. But if you get the polysaccharide first, there's no going back. You don't start boosting then if you give the conjugate. So it's a really good idea, but it doesn't seem like it works. It seems like you kind of get one chance, and then that's it for boosting.
You know, vaccines are just such a remarkable topic, and we're learning so much about them here at ICAAC this year. And I'd like to thank both of you for joining us here today, and I look forward to both your papers. And you've been watching ASM Live at ICAAC. I'm Michael Schmidt of the Medical University of South Carolina and This Week in Microbiology. And thank you.
Thanks a lot.
Thank you.
Extending the legacy of a classic reference, EcoSal Plus joins the ASM family of periodicals this June. This growing collection of continually published reviews reveals our ever-expanding understanding of the biology of E. coli, Salmonella, and the other Enterobacteriaceae. From cell architecture and growth to pathogenesis of infections to life in communities, EcoSal Plus is the single source of knowledge about these organisms and their use as model microbes. A distinguished editorial board, led by Editor-in-Chief James Caper, ensures that content serves the needs of the research community. Free trials available for institutions. Take a look at ecosalplus.asmblog.org.